most recent grantee is Catholic Charities, and we continue the work of dementia in this particular population. So let's look at adults and aging. Aging does not affect older persons with intellectual disabilities any harder than other people. Some changes are to be expected. Your hearing goes down, people have hearing aids, your vision gets a problem, you may have cataracts, have glasses. That is to be expected, but persons with intellectual disabilities, as they grow old, they can still learn. For example, people in a nursing home might learn bingo and they've never played bingo in their lives before, or they might learn a new card game. They can still learn, and we got to remember that aging cannot be prevented in persons with intellectual disabilities by good diet and exercise. So even if I go to the gym every day, I still may have to dye my hair and color it because my hair is getting gray. I cannot prevent it by a good diet or exercise. So that's just some basics about aging in adults with intellectual disabilities. Now, the NTG, who is this group? It is a coalition of interested persons and organizations, and their mission is to ensure the needs and interests of adults with intellectual and developmental disabilities who are affected by Alzheimer's and other dementias are taken into account as part of NAPA. And NAPA is the National Alzheimer's Project Act. And because of their advocacy, it is now in a federal statute, it's in law. So anyone getting federal dollars and grantees need to remember about this particular group. They're considered a vulnerable population. So what is the risk of dementia in intellectual disabilities? Most adults are no more at risk than the general population, except adults with Down syndrome who are at higher risk. And they have a more rapid progression, and it starts at a much earlier age, like in their 40s and 50s. So this is telling you that people with Down syndrome, by the time they turn about 60, more than half, 56% of persons with Down syndrome will have dementia. Now, the ones with just intellectual disabilities, it's matching or mirroring the regular population, which is 1 in 3 persons over the age of 85, 1 in 9 over the age of 65. So we got to remember that dementia is not a part of normal aging. Everyone who grows old is not going to develop dementia. The statistics in the general population is 1 in 9 if you're over the age of 65 and 1 in 3 if you're over the age of 85. What about Hawaii? How common is Alzheimer's dementia in Hawaii? And this is from the Alzheimer's Association facts and figures. All across the US, it's more than about 5 million. And in Hawaii, last numbers was about 27,000. However, these numbers are just the tip of the iceberg because we feel a lot of people don't even have the diagnosis. In their ICD-9 and ICD-10, it might just say forgetfulness or memory impairment. The providers often don't have the time to go into the diagnosis. Families think they're just getting old, what do you expect? So a lot of people are undiagnosed. Let's do a little refresher on what is Down syndrome. This we all learned in nursing school, in medical school. Down syndrome was first described by an English physician, John Langdon Down, and it's named after him. It is a developmental disability that has both intellectual impairment and physical abnormalities. How common is it? It's 1 in 750 live births. It's a genetic abnormality where persons have a full or partial copy of chromosome 21. And we know this disease by another name. It's also called trisomy 21. So let's look at what this karyotyping. This is your chromosomes. When they karyotype your chromosomes, it looks like this. And the circle in red is chromosome 21. And you see they have 3 chromosome 21. And the features of Down syndrome are very recognizable. You see a person in the community and you can often say, oh, I think this kid or this person has Down syndrome. So not only dementia, but they're also having premature aging in Down syndrome. So the diseases that you think of grandpa and grandma, like, oh, they got heart problems, they got osteoporosis, all these things actually happening 20 years earlier in persons with Down syndrome. They are aging prematurely in their 50s. So I want to go over this slide, just telling you, because many people get so confused, what is dementia, what is Alzheimer's disease? Is Alzheimer's the same as dementia? Is dementia the same as Alzheimer's? So think of the flower world. In the flower world, we have so many beautiful flowers in Hawaii, right? We have plumerias, heliconias, hibiscus, and maybe you might say plumeria is the most common one. I see it everywhere. In the same way for dementia, there are many types of dementia. You can get dementia from stroke, from Parkinson's disease, there's Lewy body dementia, but the most commonest dementia is Alzheimer's dementia. Nearly 60 to 80% of dementia is Alzheimer's dementia. So if you just guessed, and maybe you're not a doctor and you just said, I think grandpa has Alzheimer's dementia, maybe 60 to 80% you might be right. That's a pretty good guess. So what is Alzheimer's disease? It is the most common form of dementia. It has a very gradual onset. So many people often cannot pinpoint the time or cannot say when the memory problem began. And it typically affects the short-term memory. There is generalized brain atrophy, so there's shrinking of the brain, and we see this classic amyloid plaques and tangles. Now, these pictures are taken from autopsy because, you know, no one goes and gets a brain biopsy. This is when persons are dead, they look at the brain under microscope, and you can see in the Alzheimer's brain, you have these plaques and tangles versus the bottom figure has the healthy cells, the healthy neurons. John, do you think we can play this video? Oh, yes, it's coming. But we don't have volume.
I think it works on their end.
Yeah, how do you get the volume up? Okay.
I don't know.
Okay, that's
they can hear on their end.
That's all right. This is a nice video which you can also find on YouTube after the slides will be provided to you, and you can see this video which talks about the different stages of Alzheimer's and how it progresses.
I think that is coming out on their end.
Okay. You think it's coming on the end?
Yeah, it was coming out on this computer.
Oh, and let it play.
Put in the chat, ask the chat room if you can hear it. There's no sound. There's no sound.
They cannot hear it? Okay, then we'll just move on. So why focus on Alzheimer's? It's because Alzheimer's often presents differently in persons with Down syndrome. So it's not similar to what we think of in grandpa and grandma. Often a person with Down syndrome might have new onset seizure activity when they have never had any seizures in the past. Or they might develop incontinence when they have always been independent in toileting. They might have disturbance in sleep-wake cycle. So things that are different from their baseline, we need to pay attention because this might be the starting signs of Alzheimer's disease. So dementia affects all aspects of functional abilities, not only their memory, it also affects language, reasoning, ability to sequence tasks, sensory perception. It affects a lot of aspects. So One has to think of all of these areas as part of the solution or part of coming up with a care plan. Now, what we have found is that the traditional screening tools are not useful. So what you learned in medical school, in nursing school, in social work school, those tools are not useful. The mini-cog is not useful. The MMSE is not useful. So what the NTG did, they came up with a screening tool, and we have this handout for you all to take a look at. It's on the ECHO website. And this tool is called the EDSD, Early Detection Screen for Dementia. So it's a 6-page tool, and we are to administer this for persons with Down syndrome beginning at age 30 and then annually. For non-Down syndrome, the recommendation is to begin at age 50. So what are the different parts of this tool? Page 1 and 2 has basic information. Page 3 and 4 goes into the functioning ability of the person. Page 5 is their comorbidities and other conditions. And page 6 is the medications. So these are the 4 key sections: demographic, health, mental health, and life stressors, their functioning, and chronic conditions. Now the question is, who's going to do these 6 pages? Who has the time? Everyone is very busy. So according to the NTG, any caregiver or family or staff, whoever is familiar with the patient, who's known the person for a minimum of 6 months, who has access to the person's record, can complete the NTG, EDSD. So you don't have to be an RN or MD to do this. There is no special qualifications required. So where do you get your information? From the person, from the family, from the medical records. NTG also recommends taking short digital videos which can show how a person performs their certain tasks, like just putting on a shirt or eating their lunch. It's just simple short videos to see their functioning ability in certain tasks is also helpful, because you will see the progression over time. What happens after you complete this form? One interesting part about the form is there is no score. Every test that we do for dementia, you get some points and you come up with a score. The EDSD, there is nothing to add up. There's no numbers in this. All that we're seeing is change from last year's EDSD. So you're looking at change from baseline, change over time. And if there's any changes, then please discuss this with their case manager. Many people may have a DDD case manager or somebody from their waiver provider like ARC, Easter Seals. There's case managers, supervisors. Bring it to their attention. Let a copy go into the waiver provider's chart. Give a copy to the primary care physician, because then a person needs some workup for dementia. So what happens in the next step after EDSD is done? The provider will do a history and physical, some blood tests, and we do the usual tests for dementia, but one additional test in this group is ruling out for celiac disease. And an MRI or CT scan may be done. Look at what we see on the brain scan. The areas in red, blue, and green, that's the hippocampus. That's the memory areas in the brain. And you see the figure on the right-hand side, those areas are shrunken. And the white matter of the brain is also shrunken. That's cortical atrophy. And you're seeing more fluid, which is the cerebrospinal fluid in black. So there's cortical atrophy and shrinking of the brain. What about medications? Are they useful in this population? The NTG does not recommend any of these medications because they found that it has very limited value in persons with Down syndrome. Vascular dementia, that is another type of dementia where you often see a stepwise downward progression, because often people have many mini strokes. Sometimes people have strokes and they don't know they've had a stroke. But there are other types of dementia. And you can get dementia from, repeated head trauma. We have, NFL players in Hawaii, they've had head trauma and they develop dementia. So there are many types of dementia, but I'm just mentioning the vascular here. So let's come to the key concepts in dementia care, because we don't have any good medications. So what can we do for these persons? And the NTG advocates for maintaining support, life story, redirection, validation, and not to reorient persons. And I'm going to discuss each of these concepts. So maintaining support is considered best practice. It's a proactive approach that can often help reduce difficult behaviors. It can be done in any settings, and the focus is on the remaining abilities. That means we are focusing on the glass is half full, not that the glass is half empty. You got to see the rainbow in these clouds. You got to see the silver lining here. So the key concept is, let's focus on what the person can still do, not what they cannot do or what they have lost. Another key concept in dementia care is honoring their life stories. We got to realize that a lot of people have shifted around a lot. They have moved maybe from one foster home to another home. They may have moved from one island and now they're on Oahu. So often the life story might be lost. We don't know what's their essence, what's their family, where they came from. And this is very important especially when someone is no longer with their family and living in a care home or a foster home. Let's honor their story. Let's put their photographs up. Let's put their medals where people can see it. Let's personalize their room so we honor and respect and give them the dignity that they deserve. Another approach is the validation approach. It's another key concept in dementia care, where you're focusing on empathy and understanding. And if you do this, we can greatly reduce stress and agitation and need for medication. Let me give you an example of validation. John says, someone stole my book. Now, you could answer, John, you always say that. You misplace your book all the time and you blame other people. Or you could say, I'd be upset too if that happened to me. I'll help you look for it. So in the validation theory, you are joining the person in their reality. You're going into their world and you understand what their emotions are, and you just join them in their reality. It's very hard for us in the medical field because we have answers, solutions, we want to fix a problem. And in validation, you're not fixing anything. You're just joining them in their reality, in their world. Another key concept in dementia care is, should we reorient them or should we not reorient them? Today's best practice in dementia care is do not correct or try to reorient the person. And this is very hard for staff. It's very hard for people who just graduate from social work school, graduate from nursing school, medical school, because they find this so difficult. You want me to lie to the patient? So let's look at this example. What time is my mother coming? And you know Ken's mother died 20 years ago. Which response is better? Your mother is dead, Ken. Your sister will pick you up at 4 o'clock. That's response A. Or response B, she'll be here in a little while. Let's get a dish of ice cream while we wait. So in today's best practice, response B is a better response. It's a kinder response, because if you reoriented this person, they might grieve again. They might not know their mother had died and they will start crying and grieving again. So B is a better response. What about redirection? Distract and divert is a very good technique, and often you see this used beautifully in kindergarten. In daycare, when parents drop off their kids, the daycare teacher, the kindergarten teacher is really good in distracting and redirecting the child so they don't say, "Mommy, mommy, mommy, I want to go home." They know how to then stay on in the daycare and the kindergarten. So we have to do similar techniques in this group. So we gently distract them and then suggest another desired activity. Let's remember that all behavior is communication. So one has to be like a detective to handle difficult behavior. Some communication strategies, some basic 101 is speak slowly, use short, familiar words, give enough time to respond. So for example, I wouldn't ask the person, "What do you want to eat for lunch?" Now, there are thousands of things you can eat for lunch. You could just make it simple and say, "Would you like a chicken sandwich or a fish sandwich for lunch?" Now, we've given some choices and we've simplified it. Another dementia communication 101 is don't argue, don't disagree. Remember, let's redirect them, let's join, validate, and distract. Also in dementia, people lose their peripheral vision. A lot of their visual field gets diminished. So whenever you're talking to a person with dementia, approach them from the front. Come in front of them and speak with them. Don't give instructions from the side. Let them see your face. Let them see you, and then you tell them what you would like. So caring for someone with dementia requires a shift in thinking. And this is hard for us in the medical field because we are very familiar with the word rehab. You go to rehab if you break your hip, you go to rehab for drug and alcohol, you go for rehab for stroke. But in dementia, we have this new word called habilitation, which is a term used by dementia professionals to describe the non-medical interventions which are considered best practices. So the focus is maintaining function, safety, and comfort. We need to adapt activities such that they are failure-free. What's the meaning of this word failure-free? We need to suit it based on the capacity of the individual. We need to have people engaged in meaningful activity. Meaningful engagement means not everybody is going to play bingo. Somebody may like to paint, and somebody may like to play a game of cards, and somebody may enjoy mahjong. So everybody doesn't have to play the same thing. We need to make sure the activities are meaningful so people don't get bored or frustrated. Let's look at this example of right-sizing the activity. Let's say I have my neighbor's kids for the weekend and now I'm babysitting these 3 children. I have a 5-year-old, a 10-year-old, and a 15-year-old. So I say, let's make chocolate chip cookies. Now, of course, everybody wants to make the cookies, right? Nobody's going to sit down. They all want to do, I want to help, I want to help. So what will I give the 5-year-old to do? Now, this is common sense. We might say, oh, 5-year-old, you could stir, you could make the little cookie dough balls. That's something a 5-year-old could do. What about the 10-year-old? Oh, they might like to measure. They might like to stir. They might like to add the ingredients. What about the 15-year-old? You might think, okay, the 15-year-old, they're bigger. They know about safety. They could set the oven temperature. They could put the tray in the oven. So this is the meaning of the word right-sizing the activity. We got to remember that in dementia, as the stage of dementia progresses, the tasks and activities we give them have to be increasingly modified. So in an earlier stage of dementia, they can do more complex tasks. but a late stage, it has to be very, very simple. This is just, thinking about if I were to say, let's make a sandwich. Do you know how many steps go into just a simple thing like let's make a sandwich? There's a lot of steps in this. So similarly in dementia, we got to remember to break down the steps. Our instructions to caregiver is break down the steps. Whether we say take a bath, take a shower, there's so many steps in taking a shower. So tell the caregivers to break down these skills into tiny, tiny steps so it's easy for the person. NTG focuses a lot on the environment. The environment has a very big role to play in this population. We got to remember things like noise, lighting, number of people in the room, especially in Hawaii, and we're dealing with so many ethnicities and Pacific Islanders. It's a norm for them for like 10, 20 people to be in the hospital room. That may be large number of people, and that might be overstimulating. Sometimes we have the problem of understimulation, and sometimes we have the problem of overstimulation. You got to look at the environment and see, are there cues for people to find their way? And we're going to show you some more things on this. So in dementia, let's remember we don't want people to fall, remove any obstacles, create an environment that's supportive to the caregiver as well as the adult, lock or disguise hazardous object. And how would you disguise a hazardous object? So say if you're worried about somebody wandering and you're worried about a door, them running out of the door, you can disguise a door if you paint it the same color as the wall. So in the wall and the door are the same color. You can disguise the door. So what about other things like using pictures, cues, signs? All this is very helpful in maximizing location and function. You might say, what is this red and white toilet? It looks so funny. But these contrasting colors are important for persons with intellectual disabilities who get dementia, because their vision gets affected, and contrasting colors is very important. Also, when you see different nursing homes, you wonder, why ever did they paint these horrible colors? And sometimes nursing homes are deliberately painted these colors to give contrast. What about wandering? What can you do if somebody is wandering? We don't want to restrain them. We need to promote exercise. Do not prevent the movement. So how can we exercise? You can dance, you can put the music on. These are things that help people use that energy and move. They want to move. You can disguise the doors and the knobs. There's a lot of things out there with technology where you can have GPS wristbands. There's also the Alzheimer's Association, and we have Alzheimer's Association on all the islands in Hawaii, and they have an excellent program called the Safe Return Program. So in this program, they have the photograph of the person who is at risk for wandering, and all your first responders from the police, fire, they all know, they have this person in their database. So if somebody's going missing, they can search for them immediately. You don't have to wait for that 24-hour rule that, an adult is declared missing only after 24 hours. So you bypass that 24-hour waiting period. What about dementia and vision? We have to remember that the visual field is reduced, that they have depth perception problems. It's very hard for people to drive in the night. They have problems with shapes, sizes, visual memories. So what can we do? First thing is reduce the visual clutter. We want to organize stuff in appropriate places. Identify clearly defined walking paths. Sometimes you see nursing homes, they have this figure of 8 or an infinity, because it really helps people who like to walk and wander. They feel like they're walking and walking and walking and walking. Think about glare. We also need to reduce glare because it really becomes hard on the eyes. And we can do that by using matted surfaces, low gloss surfaces, no gloss waxes, and cleaning products. What about those who have hearing challenges? This also happens, and we got to remember that persons with dementia, in this particular population, there's increased incidence of hearing loss. And one study reported nearly 83% of people with early to mid-stage dementia in this population has hearing loss. So think about noise pollution. We don't realize about our air conditioning, the TV, the radio. There's a lot of noise. You got to think, if persons have their hearing aid, are they using their hearing aid? We have a lot of people with hearing aids who don't like to use it. They don't like changing the battery. They feel it's whistling in their ears, that it's more of a headache. So one has to address hearing challenges. We can reduce our background noise. Soft material like carpeting is helpful because carpeting reduces the noise when people walk. And when you're speaking to someone, it's important to face them when you speak to them, because a lot of people with hearing impairment, what do? They compensate by reading your lips. So they can only read your lips if they can see your face. So we have to tell the staff, give simple, short direction and pieces of information at one time. Don't give complicated directions or complicated sentences. Make it short and simple. Speak at the eye level after gaining eye contact. Wait longer for the response than in the past. Let's look at this picture. Now, what's wrong with this picture? Now, if you were on the Nate Burkett show and you had an unlimited budget and all the money, and I told you, go ahead and change this, what would you change in this residence? This is a residence for adults with intellectual disabilities, like a group home. What do you not like about this group home? If you notice, maybe the color of the couch is dark brown to black, and those hardwood floors are also dark brown. So it's brown on brown. Now, what's easier to change? It's easier to go out and buy a new couch, right? That can be done today. If I want to change those floors, it's a little more complicated. So one thing is to use contrasting furniture. What else? You might look at this room and say, what else is an issue? The glare. How do we reduce that glare? We can get different blinds, or you could use curtains, for example, to diminish the lights to reduce the glare. So these are little things that we can do to make the environment more conducive. Now look at these two photographs. You know, a big problem that foster home operators or care home operators have is they say the person is peeing outside the toilet, or he's purposely doing it, purposely peeing outside. And one has to remember that everything is white. We have white toilet seat, white toilet bowl, white hand, everything is white. There's no contrast. So a simple thing you can do is to change the toilet seat cover. You can go to Home Depot and buy a wooden toilet seat cover. It doesn't have to be red. You can get it in brown. But a simple thing like that can add contrast in a completely white toilet setting. Another trick somebody shared with me, a case manager from DDD told me that, doctor, you can use these cleaners. They have this blue color. They change the water of the toilet bowl, and that also gives you a sense of depth and perception. What's wrong with this picture? This is your nursing home. We have white table covers, we have a white plate, then we have a white coffee mug, we have a white napkin, white fork. There is no contrast here. And then we wonder why people are losing weight. We'll give them a white chicken, white mashed potato, cauliflower, and then we wonder they're not eating, they're losing weight. So think about how you can change this. A simple placemat, you can just have a placemat of a different color, and that could solve the problem and give some depth perception. Now we're going to move to the last piece of this. We're coming to the end because I'm so interested for you guys to get a $150 gift card, right? Somebody's going to present a case or even have a case. So we're going to get that gift card. The last part of this is the caregivers. Caregiving in this population is very, very, very hard. And why is that so? You know, in the old days, what did the doctors tell the families? They told the families that your loved one is only going to live to teenage or young adult, and then they will die. So people never thought that their brother or their sister or their auntie or uncle was going to live that long. So the life expectancy from the 1930s to the 1990s, in the 1930s, people only lived an average of 18.5 years. In the 1990s, they were living all the way to 66.2 years. So there was a huge gain in life expectancy. So a lot of people, there were many families that had secrets. They never told about this brother or this sister. And they also thought that the person was going to die when they got into their early 20s. They didn't think that this child would be around for that long. But things have changed with science and technology. People are living longer. The life expectancy for everyone has gone up in all countries. So you got to wonder, where are these people living? 75% are living at home with their parent, spouse, or family caregiver. They are not locked up somewhere. They are not living in some residential facilities or this. Most people are in the community. 13% might be living alone. So there's a lot of caregivers for this population. We have to understand there's a unique challenge of caregiving for an adult child with intellectual disabilities and dementia. You know, in Hawaii, when you hear about, oh, my sister left her job in California and came back to take care of mom and dad. When you hear about a family member who returned back to the island to take care of mom and dad, how many years of caregiving are we looking into? It's usually 3 to 5 years. But parents with a child with intellectual disabilities, that's like 60 years or more of caregiving. It's a career. It's a lifelong career of caregiving. And we need to have deep compassion for this particular group, because they are at risk for so many things. You know, being a caregiver, you have your own health issues, your own aging, and a big problem, what's top on their mind is the concern of the long-term care of the care recipient. So parents wonder, who will care for their child when they die? Who is going to pay for the care? Who will provide it? And we cannot assume that the brother or sister is going to take that person in, because that often does not happen. The brother and sister have their own lives. They're married. They have their own families. So when we make care plans, when we are care planning for this particular group, one has to remember these questions, because they're top on people's mind. If once I die, who's going to take care of my loved one? So remember, connect them to resources. We've got 2 wonderful resources in the community, the Alzheimer's Association, persons with Down syndrome, persons with intellectual disabilities who have dementia. Welcome to access this resource. You don't have to even have the diagnosis of Alzheimer's disease. Anybody can phone that number. Also, we can tap into aging resources. We have the ADRCs, and that's also available to persons with Down syndrome who might need extra help. So I'd like to thank our grant funders. I'd like to thank the Developmental Disabilities Division, who has been a strong partner on this particular objective of our grant and helped us to conduct trainings on all the different islands and for their staff and caregivers. And now I'm happy to open up for questions because we have a lot of gift cards to give out.
And feel free to type in the chat box too if you're shy to speak. See, everybody's shy.
We need to give gift cards, small amount for the chats.
Hi.
Hi, it's Sarah Roxa. I don't know. I lost the Zoom connection. Can people hear me, or am I talking to myself?
We can hear you.
Oh, I can't hear anything happening. Is there a presentation, like a case?
Yeah. Well, we're waiting to see if anybody has a case to present.
Oh. I have a 40-year-old that we just admitted to our house calls program who has Down syndrome, and I'm looking to evaluate her for dementia. So I'd love to hear your thoughts. If there's nobody else talking, I'd be happy to talk.
Yeah, please share your case. There's $150 gift card.
Oh, wow, there's even perks, huh?
Yes, there's perks, and we have a scale for you to that you could conduct with this person, a new tool that we discussed earlier called the EDSD, and it's available on the Echo Geriatrics website. So you could get those 6 pages and administer that to this particular patient.
That's what, I'm looking forward to finding that. I haven't been on the ECHO website yet. So this woman is a 40-year-old with a history of Down syndrome. She has squamous cell carcinoma of the cervix. So cervical cancer, stage 3. Asthma. She was previously very obese and she carries a diagnosis of obstructive sleep apnea, but she refuses to use CPAP, and she's lost about 100 pounds in the last year and a half, predating her cancer diagnosis, but more with a diagnosis of dysphagia and them changing her diet and choosing healthier foods. So some of that was intentional. I just met her on the 5th of September, but the mom is describing behaviors that it sounds like with further history, these behaviors actually started about 10 to 12 years ago when the patient's younger sister left the home. Like she went off to college and left the house, and then the patient started having behaviors of like rocking herself and batting at her face and calling out at night. But at the time, the patient was only like 28 or 30. And it sounds like there's some progression of the behaviors just in the last year or so since her cancer diagnosis, but it's not really clear to me from the history, and having just met her and not really knowing her baseline. History-wise, it sounds like it was a behavior from a major life event where her sister was really involved in her life and there were lots of young people in the home, and then the sister moved away to the mainland for college and her sort of life orientation changed at home. It doesn't really sound like dementia to me. It sounds like it was behaviors associated with her developmental disability. But so it seems like this tool will be helpful. Now that I have it, I can go through it with her this year and go through it with her next year, or her new PCP can if she doesn't stay on our house calls program. But I don't know how early dementia really sets in. I heard you say that we usually do the screening starting at 30 and then every year after, but it's still, I don't know, the history seems doesn't seem clearly like dementia to me.
Okay, thank you, Sarah, for sharing that beautiful history. For the form, the recommendation is to do that tool at age 40 for persons with
okay.
syndrome, and they are likely to revise this recommendation. Instead of 40, they're thinking now, there's a lot of talk about doing it at 35. You bring up a very, very important point. On that tool, on the second page in block 14, they talk about life stressors in the past year. And that form is trying to capture things like what you mentioned, the system moved, somebody died, something happened, because that could explain the behavior, and it may not necessarily be dementia. So the EDSD form does capture that. They have block 14 that is trying to capture any big change that occurred in that person's life in the past 12 months. So I think you will find it interesting to complete this EDSD tool with this patient.
Yeah, I'm looking forward to it. Do you guys have other resources too to point us to as far as just learning more? We don't have a lot of our Down syndrome patients on our service, and the geriatricians here haven't had a lot of patients with the intersection of Downs and dementia. So if you have, other websites or other sources of information, just
we are
sort of get us.
As part of our grant, we're in the process of, this is the Catholic Charities grant from ACL. We are going to conduct webinars and trainings in Hawaii, where we have the NTG national experts will be conducting these. In addition, we are going to translate and revise a booklet and tailor it and adapt it to Hawaii, which will give resources and stuff for families. So there's a lot of things in the work that's part of the Catholic Charities grant for this particular group.
Oh, great. Okay. I think that's all I've got. Thank you.
Anything else you need for the case presentation, or she gets her gift card?
She gets a gift card.
You get your gift card!
Wow. I thought I was just asking a question.
No, that's a case, a full case. So great.
Awesome.
We'll be in touch with you afterwards.
Great. Thanks, Aida.
Now we have more gift cards to give out, so how about another person?
Anybody else have a case? Or a question is good too.
What about Mary or Chad? Would you like to share anything, any of your experiences?
Actually, this is a really, really great talk. I did not know about the ineffectiveness of the cholinesterase inhibitors in patients with Down syndrome. It wasn't something that I really focused a lot on or see a lot of. So that was really interesting for me.
I would just say is that public health nursing, we don't get too many clients with the developmental disabilities because of the developmental disabilities branch. They usually take really good care of those people. So I don't have too much experience, but we would maybe get some people who are a little bit intellectually slow that need a little bit more. You have to be careful in the communicating, using words that are easier for them. And of course, a lot of people that have hearing problems, you have to be real creative and conversing with them. Yeah.
I can throw a twist into my case. So the father of the patient, so one pending issue with them is that they've never pursued guardianship, and she doesn't have capacity to make her own medical decisions. So we're working with her case manager to try to help get the family to move forward on that. But another piece is that the father has a 329 card for cannabis. And I think about a month ago, they started giving the patient cannabis for her nighttime behaviors with marijuana product that they got under the father's card. And that's really helping her, in their opinion. It's been the most effective treatment that she's had so far. And we haven't really delved into how to help her from a medical side for her behaviors, but I didn't know. I feel like there's a paucity of research and all this interest right now in cannabis, in dementia, and cannabis with the elderly, but I am doubting there's a lot of research of using cannabis with people with Down syndrome or other developmental disabilities. It's not really an area that I want to be delving into with them, but now it's on my plate. So if anybody has thoughts about that, I'd be interested in hearing too.
Yeah, anecdotally, we've seen a lot of merits of cannabis for certain cancers, pain, certain behaviors. In the field of dementia, cannabis actually worsens the memory. So that is often not spoken about, or this side effect is often not discussed much, but it actually worsens the memory.
Mm-hmm.
So, maybe for this young girl, her issues is more behavior related, or she might have some behavioral health diagnosis that was missed and could have been triggered by the sister leaving.
Mm-hmm.
Thank you for that twist.
Yay.
So just want to remind people that if you go on the ECHO website, you got the link to join our ECHO on the same link, right? If you go to the ECHO website, there's an evaluation form that we would like you to fill out. It's important for grant purposes to have that evaluation form done. But also you can get CME credits as well. So definitely go and make sure you complete that as soon as we get offline today. And also, if there's no more questions, I want to encourage you to tune in next month. We're also back on, next topic will be actually a little bit different. It'll be overcoming ageism in healthcare. And Dr. Lucas Morgan, our clinical psychologist, is going to be talking about ageism in healthcare. So I think that's going to be really very different, but a very interesting discussion. Great. Thank you so much for joining us, and hope to see you again.
Thank you all. Thank you for your time.
Thank you.